they're horrified that they're in public.
And I think now I can just hand it over to Dr. Lynch to start going through the questions, and I will bring up the poll when needed.
All right. Hey guys, I'm Elaine Lynch. I'm one of the pulmonary and critical care faculty. I can't take credit for the slides. Lyndon Brown created all of these wonderful slides that I'm going to use for the presentation today, but she's sick. No disclosures. We did the breakout room. We're going to do polls with each question, and then we'll do a brief discussion. There's a lot of questions, and I think we may not get through all of them today, but I'm going to try and get through them pretty quick so we can get through as many as possible, but feel free to stop and ask me questions along the way if something comes up. So here's the first question. 25-year-old guy evaluated the emergency department for worsening shortness of breath, right-sided pleuritic chest pain, which developed an hour ago. No past medical history other than smoking cigarettes. He's a professional scuba diver. His vital signs are notable for a heart rate of 105, oxygen 92% on room air, decreased breath sounds, reduced expansion and hyperresonance to percussion. He has a large right pneumothorax. I'll give you a few minutes to try and put in some answers.
Okay, I think we've kind of converged, so I'm going to end the poll here, share the results.
All right, so we got a little bit of a spread. Nobody wanted to just observe the patient. Many people wanted to do supplemental oxygen and observation. And then a couple people were wanting to do, probably about half the folks wanted to do needle aspiration and catheter thoracostomy with pleurodesis. So great, I like that. So the answer is actually A, catheter thoracostomy followed by pleurodesis, and we can talk a little bit more about that. I don't think any of you were totally wrong, but I think there's an important key point here. And so I think, so the patient has a primary spontaneous pneumothorax. And all of these are potential options for management of spontaneous pneumothorax. If you have secondary spontaneous pneumothorax, meaning you have underlying lung disease, or you have primary spontaneous pneumothorax with a high-risk occupation, and for this patient, that's that he's a scuba diver. If you get because of the pressure changes, you have a high risk of fatality if you have a pneumothorax while you're diving. So in those two scenarios, you actually want to go ahead and you do definitive management to prevent recurrence. So that's why this patient, we would recommend a pleurodesis. All of the other options, B, C, and D, are great options for management of a primary spontaneous pneumothorax, and which one you would choose depends on the size of the pneumothorax and how symptomatic the patient is. Least invasive and for a smaller pneumothorax would be observation, then oxygen plus observation, and then needle aspiration. And, if you don't have a high-risk occupation, you recognize that the patient has a pretty high risk of reoccurrence, up to 50% within the first month. But you may, and somebody who does not have a high-risk occupation, observe and decide to treat preventatively after the second pneumothorax. Any questions about that? All right, we'll go ahead and go to the next one. So this is a 48-year-old man who's hospitalized with 4 weeks of cough and fever, unresponsive to outpatient therapy. Here's your CT scan. And which of the following do you think is the most likely diagnosis?
I should say that if this doesn't look familiar, we've thrown in a couple of quick hits that are in yellow slides. So don't worry that you haven't seen it. We're just asking you to throw in what you think.
All right. We got a pretty close divide between empyema and lung abscess. Nobody wanted to say lung cancer, and then few people voted for pleural effusion. And that's about the answer I expected. So the correct answer here is A, empyema. And we'll go through that a little bit more. So with this scenario, I think probably does not surprise me that the two most common answers were empyema and lung abscess, and they can be really difficult to differentiate on CT scan. I think the classic teaching is that you look for an acute angle for a lung abscess and an obtuse angle for an empyema, but I think that this is a clear indication that the boards do not want you to use that criteria. And I think in real life, that criteria is not actually as helpful as we like to think it is. There's, I think, two clues here that suggest that this is more of an empyema than a lung abscess. One is that lung abscesses usually, right, have a connection to the outside world. And so often you will see air within the fluid cavity. So you'll see sort of a air fluid level. And that's why, right, we don't need to drain lung abscesses. We think that they're going to drain naturally through the airways. The other clue is that lung abscesses are usually contained within an area of pneumonia. And so you wouldn't necessarily see quite as sort of lenticular of an area of consolidation around the fluid collection. That the fact that it's so smooth and regular suggests that this is more compressive atelectasis from the empyema rather than like an area of necrotic lung or a lung abscess within a pneumonia. Pleural effusion can sometimes look like this if it's loculated, but the fact that there's such a thick rim around it all the way around is a suggestion that this is an empyema rather than more of a simple loculated pleural effusion. Okay, and then lung cancer, you typically don't see quite as big of a fluid collection in it. And I think none of you guys really thought it was that. All right, next question. So 21-year-old woman evaluated in the emergency department for an asthma exacerbation. She typically uses a budesonide formoterol inhaler. Her vital signs are notable for a slightly elevated respiratory rate in 26. She's on 6 liters, satting 90%. She's upright, sitting upright and diaphoretic, using accessory muscles with nasal flaring. And when you listen to her, minimal air movement, faint expiratory wheezing on auscultation, and she's speaking in short sentences. She looks confused and anxious, and her gas shows a pH of 7.35, PCO2 of 45, and PO2 of 60. What do you want to do next? All right, so most people wanted to go ahead and intubate her. There were a couple votes for high flow nasal cannula and non-invasive positive pressure ventilation. Nobody wanted to do heliacs. All right, so the correct answer here is intubation with mechanical ventilation. So that sort of crowdsourced the correct answer here. And I'll talk a little bit why B and C are not correct in this particular scenario, but are correct answers sometimes for respiratory failure. So for this patient, I think the key things here are, A, this is asthma and not COPD. And I think the database for using non-invasive ventilation in asthma is a little bit different than COPD. In COPD, there's really clear indication that trial of NIPPV in patients often can decrease intubations and decrease mortality. In asthma, it's not as clear, and in some patients, there is indication that using NIPPV first increases mortality for the patients that fail and ultimately go on to intubation. The indications for her that she's got impending respiratory failure are her respiratory distress, and her gas, which shows actually not a respiratory alkalosis, which we normally see with patients with respiratory distress and that don't typically have hypercarbic respiratory failure, but actually a slight increase in her PCO2. So in a patient with asthma, that's seeing that the PCO2 is starting to rise, is typically something that should trigger you to think on a board question about intubation. High flow nasal cannula is a great option in patients with ARDS or pneumonia, but there's less evidence that sort of mechanism of action would be helpful in somebody with asthma. And then Heliox, none of you wanted to pick that. There's some evidence that maybe it's helpful in like large airway obstruction, less so in small airway. And I think it's important to remember that this is a pretty temporary intervention. This is like, we usually, the hospital usually only has a couple of hours worth of Heliox at any given time. So not probably the definitive management for this patient. All right. Another quick hitter. So 69-year-old man with chronic dyspnea without cough. He has PFTs that show COPD. And here's his chest x-ray. So what do you think is the most likely diagnosis based off of the chest x-ray? All right. So we got a couple of votes for bronchiectasis, a couple of votes for left lower lobe pneumonia, and a lot of votes for bullous lung disease. Okay. So the answer is bullous lung disease. And I think the question, there's a couple of questions. So why is there a difference between the two bases as far as lucency or whiteness? Is the abnormal side the dark side or the abnormal side the light side? The other thing is there's a little bit of infiltrate or maybe increased lung markings just above that area of hyperlucency. So a clue for this is that on the lateral, you see that the base is actually more lucent than expected. So that's a clue that the abnormal side is actually the lucent side rather than the other side. So that sort of suggests that the abnormality is in the right lung base. And I think the sort of the increased infiltrates above that is actually atelectasis of the lung tissue above the bulla rather than an evidence of something else going on there. All right. And I think the other thing is, the patient's history of potential COPD based off of his PFTs and the evidence of flattened lung diaphragms and a large lung, that all sort of goes along with bullous lung disease. That can be a concomitant condition. All right. So now we have a 55-year-old woman who's hospitalized for daytime sleepiness that's progressed since discharge from the hospital 2 days ago. She'd had a right knee arthroplasty for osteoarthritis. She has a history of obesity, hypertension, diabetes. She's on lisinopril, metformin, liraglutide, and she's newly been started on oxycodone and enoxaparin. You've got her vital signs there. She's got a respiratory rate of 12, oxygen saturation of 94% on 5 liters, BMI is 44. She's sleepy, but you can wake her up and talk to her. Her lung sounds are distant. Her wound looks okay. And her ABG shows a pH of 7.25, PCO2 of 78, and PO2 of 66 with a bicarb of 33. And she has PFTs that showed a restrictive pattern and an X-ray that shows small lung fields. All right, we got an even divide between BiPAP and CPAP. Great. So the answer for this question is BiPAP. And I think the key, there's a couple of keys here. I think that, so you have a patient who has a high BMI and is presenting with hypercarbic respiratory failure. And in this scenario, the most likely diagnosis is that she has obesity hypoventilation syndrome that's been worsened by the use of oxycodone. The difference, and it's like often patients with obesity hypoventilation syndrome also have severe sleep disordered breathing. And for some of those patients, actually initiation of CPAP is enough, but to actually know that, you need to do a sleep study. So for the acute management and somebody who presents with probable obesity hypoventilation syndrome is actually BiPAP until they can get a sleep study. The clues here, I think, for this include the fact that she has a low respiratory rate. She's pretty arousable, so you wouldn't, necessarily jump to intubation with mechanical ventilation, although that can be a necessary maneuver in somebody with a really bad decompensation of their obesity hypoventilation. And the fact that she has a serum bicarb that's elevated suggests that she probably has chronic hypoventilation. The acetazolamide I would be surprised if that ends up being an answer for a question like this. Acetazolamide has poor data for use in patients with chronic hypercarbic respiratory failure, and actually in some cases can worsen hypercarbia acutely because it affects the transporter in the red blood cells as well. Okay. Oops, I didn't include all of this stuff, but I think we covered all of this. All right, so the next question, 56-year-old man with COPD of exacerbation consisting of cough and increased sputum production. This is the chest x-ray. And what do you think is the most likely diagnosis?
I can always tell when people are unsure because they're slow in clicking something.
All right, pretty good split here. So we've got right lower lobe atelectasis, right lower lobe pneumonia, right middle lobe atelectasis, right middle lobe pneumonia. So the answer here, so this is awesome. We've got a lot of different ideas about it. So this is actually a right middle lobe atelectasis. And I think, so here are the two clues. So one, you know that it's something in the right middle lobe because you got your silhouette sign on your right heart border. So that's your clue that there's something going on in the right middle lobe. This alone doesn't give you enough to know whether it's a pneumonia or atelectasis or what the process is. The second clue is this wedge-shaped opacity on the lateral, which shows a really defined edges. And those edges are actually your major fissure and your minor fissure. And so seeing something that looks like this, that's pretty suspicious for a right middle lobe atelectasis rather than a pneumonia, which shouldn't have such defined borders or be so smushed. All right. So the next question, a 53-year-old woman presents for follow-up evaluation of an incidentally found 4mm solid lung nodule in the right lower lobe on abdominal CT scan. CT scan showed no other nodules, no lymphadenopathy, unremarkable lung parenchyma. There are no old scans. She has no personal or family history of lung cancer. She's asymptomatic. She's a non-smoker. no significant exposure history. So what do you think is the most appropriate next step in management?
There's lots of commentary about how the radiology reports oftentimes don't distinguish between atelectasis versus pneumonia.
Classic hedge.
Sorry, my poll only, I'm gonna redo the poll because it has the wrong number of, thanks, Hudson. Wrong number. Here we go. Okay, sorry guys.
All right. Pretty even split between B and E. One person voting for C. All right, great. So B and E would be the most common options for follow-up of a small incidentally found lung nodule. And the difference between the two is whether or not you think the patient is high risk or low risk. This patient is low risk. She has no prior history of lung cancer. She's a never smoker. She has no symptoms, nothing to make you sort of have a suspicion for lung cancer. There are lung cancer risk determinators to try and figure out your pretest probability for lung cancer. I think the most commonly used one is the Brock calculator. If somebody is high risk, you might do a CT chest in 12 months for a 4 mm solid lung nodule. With a nodule this small, it's actually not very useful to try and go ahead with biopsy. CT guided lung biopsy typically can't get something that's less than a 0.5 millimeter. PET is also highly likely to be negative, even if it's a false negative and something that's less than 8 millimeters. I just remember a 0.5 millimeter because I think that's easiest to remember. The only thing that really you could potentially biopsy that's that small is if something's in the airway by bronchoscopy. But that typically you might not even see that on a CT scan. So I think for something that's incidentally found in small, agree that B and E are the most likely options, and then you just need to think about whether or not you think this patient's high risk or not. All right. A 66-year-old man comes in for gradually progressive dyspnea and dry cough over the past 6 months. He has a 30-pack-year smoking history, and he quit 10 years ago. No other past medical history. He has a respiratory rate of 22. He's 93% on room air. He has fine end inspiratory Velcro-like crackles at the bilateral bases, and he's got clubbing. Spirometry is as shown here, and we got a high-res CT to help us decide what's going on. All right. So most people are voting for idiopathic pulmonary fibrosis and a couple of votes for cryptogenic organizing pneumonia, NSIP, and RB-ILD. So the answer here is IPF. And I think the clues here are that they're showing you the bases of the lungs, where there's a fair amount of sort of thickened septa, evidence of reticulation fibrosis. And then here you've got evidence of honeycombing. And honeycombing should really clue you into IPF. So you see these sort of regular round sort of cyst-like structures at the base of the lung. Honeycombing is not a common presentation when it comes to non-specific interstitial pneumonia. That's more commonly, you still will see lower lobe predominant fibrosis. You often see ground glass opacities, but honeycombing is not a typical finding for that. Cryptogenic organizing pneumonia typically looks more like a pneumonia. And the patients often present like the classic illness script is recurrent pneumonia or incompletely treated pneumonia despite multiple courses of antibiotics. And then the illness script for RB-ILD is somebody who's an active smoker. And you usually we'll see sort of like ground glass nodules on CT. So this patient, for IPF, it's the most common cause of diffuse parenchymal lung disease, and it's usually sort of your older patient with the classic risk factors for chronic heart disease, chronic lung disease. So smoking, older, they might have other comorbidities associated with it. All right. So you have a 66-year-old woman who's in the ICU for acute hypoxic respiratory failure due to viral pneumonia. She's no past medical history and no meds. She's afebrile, blood pressure 140/90, heart rate 100. She's satting 88% on 5 liters, and she's breathing 32 times a minute. She looks calm. She's interactive. She's a little tachycardic. And on her lung sounds, she's tachypnic with bilateral rhonchi. Her blood gas shows a pH of 7.4. Her PCO2 is 37. Her PO2 is 58. And she has bilateral diffuse opacities. What would you do next for this patient? All right. Most people want to start high flow nasal cannula. Got a couple of votes for non-invasive positive pressure ventilation, current management, and intubation. Good. So the answer is high flow nasal cannula. And the reason for that is, so this patient has a viral pneumonia and she's got sort of progressive hypoxemic respiratory failure. In the setting of hypoxemic respiratory failure without hypercarbia and no significant respiratory distress, I wouldn't necessarily start non-invasive positive pressure ventilation. I think the other key here is that in patients with respiratory failure due to pneumonia or ARDS that don't have underlying hypercarbic lung disease, it can be associated with delay in intubation and increased mortality. So that's typically not on my sort of acute hypoxic respiratory failure management pathway without underlying hypercarbic lung disease. Intubation may be where this case is headed. The patient sounds like they're not doing very well and they're requiring a fair amount of support. However, if they're sort of alert, interactive, and they don't look like they're in respiratory distress, there is evidence that high flow nasal cannula can prevent some intubations and may be associated with better outcomes. So there is pretty good evidence to start with high flow nasal cannula with the caveat that that person may still require mechanical ventilation. And then they'll, continue with current management. While the patient looks okay, we do, there's not great evidence for this, but we do still try to shoot for a SAT between sort of like 90 and 96% if we can manage it. Of course, in severe ARDS and somebody's sort of already maximally medically managed, we may allow a lower SAT goal, but if we have the tools to do it, we'll try to shoot for a higher one. All right. Got a 76-year-old man who comes in with a 9-month history of progressive dyspnea without cough or wheezing. Got a chest CT scan here. What's the most likely diagnosis? All right, so we got a even split between asbestosis and mesothelioma, and a couple people voting for IPF or NSIP. You guys, this was a really hard one. I thought it was hard. The answer is asbestosis. And there's a couple of clues here. So I think the main clue here is what's shown on the left on the mediastinal view of the CT, which is basically little areas of calcified plaques peripherally. And there's not a lot of things that cause calcified plaques. I think the calcified pleural plaques is like a pathognomonic thing for asbestosis. And the differential is pretty narrow. Besides that, you can maybe think of like history of pleural trauma, like maybe a prior accident with the hemothorax or a prior empyema, but to have bilateral pleural plaques like that in somebody who doesn't have a history of an inciting cause, that's pretty suggestive of prior asbestosis. And then here you also see some areas of, on the right, you see some areas of pleural thickening. But I think importantly, we don't see a lot of fibrosis or ground glass that would be suggestive of one of the other sort of intraparenchymal diagnoses. The one thing to know, though, is that in advanced asbestosis, you can see findings that are consistent with UIP or that look essentially like IPF.
Eileen, since mesothelioma was commonly guessed here, what would be seen if this were mesothelioma?
Yeah, I mean, I think the fact that there's just pleural plaques and not a huge area of pleural irregularity or pleural effusion, that would be things that would make me suspicious that there was something more localized to one side. But there's just very narrow, sort of thin calcified pleural plaques here. But yeah, that's a good. Yeah, thanks for bringing me back to that.
Well, and I think it's also probably for the board's purposes would be unusual not to have an exposure history that might be suggestive of some sort of exposure to mesothelioma.
Mm-hmm. Yeah. All right. So the next question, we had a 63-year-old woman who has increasing dyspnea for the last 2 months. Her past medical history includes ischemic cardiomyopathy and breast cancer. She previously worked installing brakes on cars between the ages of 20 and 30. She's on goal-directed medical therapy for CHF. She has an S2 mitral regurg with a murmur, or mitral regurgitation murmur, bilateral lower extremity edema, and her left base has dullness to percussion and absent breath sounds. On an abdominal exam, you feel an enlarged liver and possible ascites. And on X-ray, she has a moderate pleural effusion that's otherwise normal. You do a thora with 600 cc's of serous fluid removed, and here are your fluid studies. What do you think is the most likely diagnosis? All right, almost everybody thought this was a malignant pleural effusion. There was some votes for heart failure as well. All right, so the answer is indeed malignant pleural effusion. And so I think there's a couple of key things. So it sounds like most of you sort of looked through the pleural fluid studies and saw that this is sort of significant for an exudative pleural effusion by Light's criteria, which should help rule out heart failure and hepatic hydrothorax, because both of those would typically be transudative pleural effusions. So that leaves you with benign asbestos pleural effusion. And it sounds like none of you guys got sidetracked this red herring of installing brakes on cars, which is a classic history of asbestos exposure. And while this could be consistent with an asbestos, a benign asbestos pleural effusion, common things being common in a patient with a prior history of cancer, that's going to be the most likely sort of diagnosis, looking for a horse rather than a zebra. The other thing that would point you away from a benign asbestos pleural effusion is the fact that that's usually associated with those calcified pleural plaques that we saw in the last case. So the fact that they didn't see that on the chest X-ray should make you think a little bit less about asbestos and a little bit more about other etiologies. All right. Got another imaging case here. It's a 38-year-old woman with a 10-week history of fever and dyspnea and infiltrates on chest X-ray. She's had 2 courses of antibiotics with no improvement. She doesn't smoke, and you got your CT scan here. All right. Most people wanted to say A, cryptogenic organizing pneumonia, and a couple people chose C. Great. So the answer is indeed cryptogenic organizing pneumonia. And we talked about this briefly earlier, but this is the classic illness script. Somebody who sounds like they have pneumonia, but has received multiple courses of antibiotics and has either not improved at all or has had some improvement and then relapsed again. The imaging is consistent as well. You typically see sort of peripheral predominant consolidations or ground glass. For the other things, we saw that example of idiopathic pulmonary fibrosis, where there's really a sort of a fibrosis predominant picture with honeycombing. Sarcoidosis may present with pulmonary nodules, and it may also be, this person also has some nodules sort of in a bronchovascular distribution, but sarcoid actually is more typically sort of associated with upper lobe disease rather than lower lobe disease. The other thing is, I think that you would probably, most cases of sarcoidosis that are associated with mediastinal lymphadenopathy. So I think it would be unusual to see a case that didn't include that piece of the puzzle. And then certainly COVID can look somewhat like this. I think that the illness, the clinical course doesn't really tie in with a COVID diagnosis. And I think the other thing is you will more often see more diffuse ground glass infiltrates rather than a focal consolidation with COVID. All right. Okay, so we have a 69-year-old man who's evaluated in the hospital for dyspnea 24 hours after he was admitted for a left inferior pubic ramus fracture. Pulmonary past medical history is unremarkable, and he takes no meds. He's got a temp of 38.2, his blood pressure is normal, his heart rate's in the 110s, his respiratory rate is 26, and he's satting 90% on 3 liters. He's got crackles at the bases. On lung exam, he has petechiae over the neck and upper trunk, and he's confused. Your X-ray shows bilateral patchy infiltrates at the bases. What do you think is the most likely diagnosis? All right, wow. Everyone honed in on fat embolism syndrome. Awesome job, guys. That is correct. So it sounds like you picked up on the major clues, which are recent orthopedic surgery, presence of petechiae, confusion, and respiratory insufficiency. So that's like the classic sort of triad of things that should make you think of a fat embolism syndrome. You don't always have all of those things, but if you have all 3 of them, I think you can be pretty clear in your diagnosis. Air embolism can present with acute respiratory insufficiency and neurological symptoms, but shouldn't be associated with a petechial rash. It's also associated with different kinds of cases, more likely neuro and ENT cases, or sort of like a penetrating injury rather than an orthopedic surgery. I've also seen it in the hospital after manipulation of like central lines and things like that. Hospital-acquired pneumonia doesn't fit given the fact that he was admitted 24 hours after his surgery. I suppose if the answer was aspiration pneumonia, that might be more of an enticing choice, like somebody who just had surgery, anesthesia, they're altered, but would not explain the petechiae. And pulmonary embolism, similarly, does not really explain the confusion or the petechiae.
Do you know the origin of the petechial rash?
I think it's distal lodging of the fat emboli, causing like microinfarcts. Yeah. Okay. I have a 55-year-old man with a 2-month-old history of shoulder pain and progressive weakness in his right hand. The pain radiates to his scapula, and he has no dyspnea or cough. He has a 30-pack-year smoking history and quit 15 years ago. His only medication is ibuprofen. He has normal vital signs, ptosis and meiosis of the right eye, some mild atrophy of the right hand muscles, and decreased grip strength, and his lungs are clear. He has normal labs, and this is his X-ray. What do you think is the best next step? Most best. All right, so a pretty good spread, actually. So we got a couple people voting for bronchoscopy with biopsy, slight majority voting for CT chest. There are a fair number wanting to do a CT-guided biopsies, and a couple wanted to do a surgical resection. All right, so the answer here is CT chest. And we'll explain a little bit more about that. So I think most of you identified that this is a person in whom you're worried about primary lung cancer causing sort of a Pancoast syndrome. So infiltration of the tumor. And you see here in the X-ray, there's a sort of a fullness up here in the right hilum, as well as sort of along the right mediastinal border. And that is a tumor that's probably invading up into the brachial plexus and causing this right hand or right arm weakness, as well as causing Horner syndrome. That's the ptosis, the meiosis, and anhidrosis. So, so I think all of you were sort of thinking on the lines of, what do we do for this tumor? How do we diagnose it and figure out how to treat it? To know really the best approach for biopsy, a CT scan is really helpful. And the reason for that is you want to do the approach that gives you the best chance of establishing the tissue diagnosis and the stage at the same time. So getting a CT scan will help you know, are there areas where there's distal metastases or distal areas, like is there nodal involvement that needs to be sampled? It also will give you a sense of, is it even a resectable tumor, or has it invaded to the point that we think that it's, into the chest wall and we don't think it's going to be resectable. For a peripheral tumor like this, bronchoscopy is typically a very basically unhelpful method of obtaining a biopsy. So a CT guided biopsy would probably be the modality of choice, unless you find that there's distal metastases or something else. But I think by far the first thing you need to do is sort of better characterize the tumor and look for other areas of potential metastases and other areas of potential tissue sampling. All right, got a 57-year-old man evaluated for progressive dyspnea over the last 5 months that's now present with minimal exertion. He denies any cough, fever, chest pain, or lower extremity edema. He's got hypertension, diabetes, history of left lower extremity DVT. He's taking lisinopril, hydrochlorothiazide, metformin, and empagliflozin. He has a BMI of 32. He has an accentuated P2 and trace bilateral lower extremity edema. His lungs are clear. His TTE shows RA enlargement, RV hypertrophy, and an estimated PA pressure of 65. And his LV function looks pretty normal. So what do you want to do next? Ooh, big spread. Okay. We got some votes, a fair number of votes for CT angiography followed by VQ scan. And then we got some votes for stress echo and D-dimer. Great. So the correct answer here is actually VQ scan. So I think in this scenario, you have a patient who has TTE findings of pulmonary hypertension, and that sort of in itself, the evidence of sort of RV remodeling and hypertrophy should be suggestive that this is a chronic issue. And so here you're worried about, since he has a history of VTE, chronic thromboembolic disease. While chest CTA is the gold standard at this point for diagnosing acute pulmonary embolism, VQ scan is actually the gold standard for chronic PE. And the reason is that as clots sort of like stay and are older, they will remodel, and you'll end up getting, in some cases, areas of circumferential clot, where on a CTA, it might just look like slight narrowing of the PEA. So to really best evaluate this, the VQ scan is the most sensitive test. So we talked about CTA. That may, like I said, that may identify chronic PEs, but this VQ is the gold standard here. D-dimer is not indicated when you're sort of working up chronic PE. And certainly if you have a high suspicion for PE, you probably aren't going to rely on a D-dimer anyways. And then this person has a pretty normal LV. And so the dobutamine stress echo be more suspicious if you were thinking about coronary artery disease and sort of angina. But for this person, we're really focusing on the right heart and the pulmonary arteries. All right. We have a 62-year-old woman with 8-month history of progressive dyspnea, dry cough, clubbing. She's continuing to smoke cigarettes, and her CT scan is shown. What do you guys think is the most likely diagnosis? All right, we got a fair number of folks choosing RBILD. We've got votes for emphysema, and we've got a couple of votes for idiopathic pulmonary fibrosis. And the answer is, in fact, idiopathic pulmonary fibrosis. So great, this is a great sort of opportunity to review this. So again, this is this is a slightly different CT than our prior IPF case. But again, you see sort of it's focused on the basis. There's areas of fibrosis down here. So these extra white lines are all fibrosis. And we have little regular areas of cysts. Those are honeycombs. Now, this patient may also have emphysema. And this area over here might be a little piece of emphysema, but the fact that there's sort of brighter lines around these areas of cysts is more voting for emphysema, honeycombing rather than emphysema. So having these sort of, rather than just a hole without a ton of outline around it, which would be suggestive of emphysema, we have a pretty well delineated cystic looking thing. And RBILD is not typically associated with fibrosis. The classic presentation is actually more of a sort of nodules and typically in a younger patient. The right big bleb look more like emphysema. Right, so here along the edge, that might be a little bit of paraseptal emphysema. This might be more similar to emphysema, but again, I think there's a little bit too much white stuff around here. It can be confusing, actually, in somebody who has both emphysema and pulmonary fibrosis to determine which findings are from emphysema and which are from pulmonary fibrosis. But I think by far in this patient, the predominant finding is this area of fibrosis with honeycombing. Is it true that you shouldn't have clubbing in COPD alone? I don't think so. You can definitely see clubbing in any sort of chronic lung disease. And sometimes you don't see clubbing at all, as you probably all well know. Okay, so that was a good one. All right. One more question. Oops. What would D be? Go back. Yeah, so that would typically be more of a sort of airway-centric ground glass nodule. So evidence of sort of a bronchiolitis, meaning airway-centric lesions, which typically present as central lobular ground glass nodules. All right, we'll go on to the next one. If I can figure out how to make my computer work. Here you go. All right. A 62-year-old man is evaluated for COPD follow-up. He quit smoking, takes medications appropriately with good MDI technique, and participates in pulmonary rehab. However, he continues to experience dyspnea with mild exertion and has diminished quality of life. He has minimal dry cough, never had an acute COPD exacerbation. His meds are fluticasone, maclidinium, vilanterol, and albuterol PRN, and he's up to date with his immunizations. His vital signs are normal. He's at 93% on room air. His breath sounds are diminished. And when he walks, he gets down to 90% while on room air. His FEV1 is 35% of predicted, and his DLCO is 42% of predicted. His chest x-ray shows upper lobe predominant emphysema. So what do you guys want to do next? All right, got a good spread. We got some folks voting for long-term azithral, a few more folks voting for lung volume reduction surgery, even more voting for roflumilast, and then a couple people voting for supplemental oxygen. Good. So the actual answer is lung volume reduction surgery. So we can talk a little bit about each of the answers. So we'll start with the lung volume reduction surgery. There is evidence that it can be helpful in quality of life as well as survival in certain patients. And so you have to be somebody who's gone through rehab. You have to be actually functional enough that you're not going to just totally crump with the surgery. But you actually have to be pretty symptomatic, right? Otherwise, you don't think that that person's going to benefit. And one of the key things is you have to have heterogeneous emphysema with upper lobe predominance so that there's a target for the surgeons to take out. So that the idea is that they take out these areas of really floppy diseased lung. That allows the lung to expand. And now you have more sort of snappy elastic lung, and it improves your your breathing mechanics. So they have to have an FEV1 and DLCO greater than 20% predicted and upper lobe predominant disease with persistent symptoms despite sort of maximal otherwise management of their COPD, including pulmonary rehab. Azithromycin is a potential option for refractory COPD, but it's typically used to decrease COPD exacerbations. It doesn't really have an effect on your chronic COPD symptoms. So he doesn't have any exacerbations that wouldn't be helpful for him. Roflumilast is similar. You can use it for patients who have a bronchitis sort of flavor, chronic bronchitis flavor of their COPD, so like high sputum production, which he doesn't have. He has a minimal dry cough, and for patients who have recurrent exacerbations in that scenario. And so he doesn't qualify for that for either of those reasons. And then supplemental O2's really only been shown to be helpful from a mortality perspective if your SpO2 is less than 88%. So since he really doesn't desaturate that low, supplemental O2 probably is not going to have any kind of survival benefit for him. All right. I think this is maybe actually our last question. So we've got a 32-year-old woman who's seen for asthma exacerbation. Previously, her asthma was well controlled, but now she's using her maintenance inhaler as well as her rescue inhaler 4 times a day with no significant improvement in symptoms. She's not having fevers, chills, chest pains, or purulent sputum, no history of intubation, no ER visits, no hospitalizations, and she's been doing what she's supposed to be doing for her meds. She's not smoking, and she takes inhaled budesonide and albuterol. Her respiratory rate's 25. She's 96% on room air, and she's speaking in full sentences. What do you guys think is the most appropriate treatment? All right. Majority of people, slight majority voted for E, change to budesonide for formoterol inhaler. Next most popular was a 5-day course of prednisone, and we had a smattering of votes for other ones. I thought this was kind of a weird question, to be honest, but the answer is in fact C, a 5-day course of prednisone. And I think in clinical practice, probably there are a lot of people who would have done E. And it probably just depends on the acuity of how quickly her symptoms changed and how symptomatic she is. But the reasoning that that was given for this is really that she had a clear change in her symptom, in her symptom frequency and severity. And that is suggestive of an asthma exacerbation. I think most of you agreed this seems like more of a mild exacerbation, can be treated as an outpatient. And the typical course is just 5 to 7 days. 14 days is probably unnecessary. And because she's not having any fevers, chills, chest pain, change in her sputum color, there's nothing to really suggest that she has an infection complicating this. So doxycycline or antibiotics in general are unnecessary. Unlike in COPD, where we often do it, even when we don't think that there's necessarily a clear infection. In asthma, we don't do it unless we think there's an associated pneumonia. And again, I think E in real life, depending on the person and the clinical presentation, might be a reasonable choice. But for this patient, just given her increasing her inhalers and really no symptomatic improvement, they're really pushing you to choose C with those clues. Questions about that?
This is usually the point where I'll mention that board questions are vetted more carefully than mix-up questions. And ones where there are two possible answers are usually weeded out by the time they appear on boards. And so this is for teaching purposes, and you shouldn't see a question poorly written like this for boards.
All right. I'll stop sharing my slides. Answers and explanations be sent out to you. I think so. Will they have access to the slides after this?
Yeah, I can send them out. I can just also check with Linda and make sure it's okay with her as well, and then send it out after the session for sure.
Okay.
Great. Well, thank you so much, Dr. Lynch. I learned a lot myself. So really appreciate that. Great talk. And I think now we can take a little bit longer of a break. Our next session is not until 10:45. So we have about a 10-minute break, and we will come back with Ananya Bhatia-Lin talking to us about race correction and PFTs.
Thank you, Elaine. This was awesome.
Thank you so much.
Thanks, guys.
Thank you. It's also a great reminder that when people don't know the answer and they talk amongst themselves, that you can get to the right answer much more frequently. Because the ones that were small groups, often people got the right answer, and the ones that were the new ones, there was a bigger spread.
I also feel like there was a big variance in how difficult the questions were. You know, some of the questions I was just like, I have no idea, and other ones seem more straightforward. So it's always interesting, like, that the questions vary a lot in difficulty too.
Yeah.
It seemed like some of the ones at the end were a bit on the harder side too. So. Okay, I will, Ananya, if you're on and want to do any tech practice, I'm happy to do that with you.
Yeah, let me see if I can share my slides and make sure they're in the appropriate, like you can see everything.
The view. Yeah, that sounds good. I'm just gonna put in your pre-test and breakout room links into the chat now.
Okay, great. So I want this to be presenter view, but I want to see the presenter, not you guys. I think this is how. What do you guys see?
Sorry, I'm muted. I see the right view. If you click on those three dots at the bottom of the screen and click presenter view there, you should be able to see the presenter view, but we won't. Does that make sense?
I can see the presenter view right now.
You're in the right thing then, because I do not. Well, just go to the first slide, actually, make sure.
Okay. What do you guys see?
Oh, I don't know if it's just my computer. I see a lot of graininess and things all over the place. Like, I don't actually see one slide. I see like a weird matchup of all the slides, but maybe it's just my internet connection.
It's doing the same thing on my computer as well.
Oh no. Okay, let me just stop.
If it doesn't work, I can also, well, share your slides for you if there's something.
Okay. Yeah, I will need presenter view, but let me try one more time.
Okay.
Oh my gosh. Okay.
Let me just.
So I'm going to share my PowerPoint. I'll go into the presenter view, and then what do you guys see?
This one always looked good. Okay, now it looks good. Now I see like the proper slides. It doesn't look like a mishmash.
See, and then if I
use you can't see presenter view. Now, if you do it that way, now I can see your presenter view though.
Okay, so how do I get you to not see my presenter?
So if you go back to the way that it worked last time, I don't know about this, but I just had her do a regular slideshow and then click like those three dots at the bottom. So close out of this.
That's what yeah. Okay,
oh, really?
So, yeah, that's what I just did.
So weird. Okay. That works for her.
Regular slideshow.
Their slideshow. And then if you click those dots at the bottom and say use presenter view, but then yeah. Oh, now I'm seeing presenter view. Let me Google it.
If you go to the screen part, is there a thing, like go back to the three dots? Under screen, are you able to, no, that's not it. I feel like there's usually a thing that you can flip.
Yeah, there's a way to do
presenter
it.
view.
Let me look on Reddit. Oh, it says if you have two. Oh, wait. Okay, wait, I think I'm seeing it here. So,
What do you guys see?
oh, apparently, if you share, what are you sharing your whole screen or just a PowerPoint window?
I was sharing the PowerPoint window.
Oh,
It looks perfect right now.
It does?
Yeah, that is.
oh yeah, now, oh wait, where?
It's a little laggy, but
Do you see your presenter view still?
I see my presenter view.
Okay, we're not seeing it anymore.
Okay, yay. Hi, Rosemary. Thank you so much for joining.
oh, you're so welcome. And by the way, I play that game like every time that I share my screen in PowerPoint. I play the, ooh, now I need to get this sorted. Ooh, it's being laggy.
Yeah, it's doing the lagging thing again. Maybe turn off, you might need to turn off, it might be like an internet connection thing.
The
Yeah,
lag.
I'm at my mom's house right now, and
What if you
there
turn off
are
your
4
camera,
people
like
working.
just to see if that reduces your bandwidth? I know it's not ideal when you're giving a talk, but no, it didn't fix anything.
Okay, we still have 5 minutes, right? Let me see if I
Yeah.
can do more. Let me try like actually sharing my
Whole thing.
my
If I mean, worst case scenario, I can like share your slides and then you can just see your presenter view and tell me when to advance to the next slide, like old fashioned style. I'll put your pre-test link and because I have your slides.
So you're saying try sharing the whole desktop.
I don't think
And
that'll
then-
fix the lagging, to be honest. I think the lagging might be an internet connection thing. No, now
What
I'm
do you
seeing
guys see?
now I'm seeing presenter view again. What did you
Okay.
do before that made it just because you had it before, but then it was
If she
just
shares
lagging?
her whole screen, I think we'll automatically see the presenter view as well.
So you just have to share the PowerPoint. Retest.
Ananya, how many screens do you have? Just the one or two?
I just have one
Mhm.
screen up on my laptop right now.
There's
Let me-
one other option if you'd like it. Maybe you don't want it. It's good at the moment. You're showing the slides the way you want them at the moment.
It's not. Yeah, I just want to make sure that it's not lagging.
Yes. Can everyone get off the Wi-Fi? It's okay. I think the lagginess, the slides I'll be on for a little bit. So hopefully, as long as my voice isn't lagging.
No, it just, I couldn't really, let's just try one more time with the next slide. It was just, sometimes it was working and sometimes it looked like just, yeah. I mean,
The weird thing is that the mouse is not laggy, it's just the PowerPoint. So
maybe it just takes a second.
Yeah,
Maybe it
it
just takes a
fixes
second.
after it updates after like 5 to 10 seconds. So
Yeah, so just like wait 5 to 10 seconds. Well, this one's not. There we go.
Ananya,
Yeah.
Ananya, try turning off your own camera also to see if it speeds up the slide changes.
We tried that. It didn't seem
okay.
to make any difference, but thanks for the suggestion. I don't know if it is the Wi-Fi. I think it's fine. It corrects after a few seconds, so we're good. Can you see
Okay.
your presenter view now?
I can see, I think, everything that I need to see. And I timed it and I'm like 20 minutes if it's just me talking. So I think I'll be okay.
Yeah, it looks perfect. And then I put the things in the chat for the pre-test in the breakout room. How many people do you want in each breakout room approximately?
How many people do we have? 50? We have 50 participants, 45 participants. Maybe we do
including
5 people for each breakout room.
It's like 9-ish breakout rooms. Yeah.
Somewhere.
I'll give us like a minute to 10:45 and then we can get started.
Nanya, I want to apologize. I may have to step away. We have an emergency plumbing situation, so.
Oh no.
Well,
that's horrible.
Fortunately, we have someone coming to the house momentarily, so.
All right, well, it's 10:45. So I will introduce our next speaker, who is one of our own internal medicine residents, Ananya Bhatia-Lin, who is going to be talking to us about race corrections in PFTs. And I will hand it over to her now to get started.
Hi, everyone. I am so excited to be giving this academic half day. Special thanks to Dr. Rosemary Adamson, who really helped me put this presentation together. And I'd be remiss if I didn't say that we're not talking about race corrections in pulmonary function testing. We're talking about the use of race-specific and race-neutral reference equations to interpret pulmonary function testing, which I think is one of the huge misconceptions about pulmonary function testing and how race is used in interpretations that hopefully we can clarify during this presentation. So I developed this talk to explore how race changes our interpretation of pulmonary function. Here are the learning objectives that I used to develop this talk. The first 2 objectives really are around how we use race in pulmonary function testing. And then the second 2 objectives focus on the implications of a switch to race-neutral reference equations, which is especially important in light of the March 2023 American Thoracic Society recommendations to switch to using race-neutral reference equations for all patients of all races.
Ananya, I can't, some of them are a little covered. Do you mind, you might just want to read 3 and 4 because it's hard to see those.
Yeah, so 3 is anticipate potential outcomes of the ATS recommendation to use the GLI race-neutral equations for patients of all races. And then I see 4 clearly on the screen.
Yeah,
for you
4's
guys.
clear now. Yep.
Here, so this is our index. In this talk, we'll be discussing the history of spirometry, the development of race-specific and race-neutral reference equations to define abnormal lung function, and the clinical implications of a switch to race-neutral reference equations. Before we get started, I would like us to take 5 minutes to complete this pre-test. There will be a pre-test and a post-test. I am expecting a lot of don't knows, which is the point in the pretest. So if you guys, the link is in the chat. Let me drop it again. And you should just be able to fill it out if you can't see the QR code. If you guys want to do like a thumbs up or hand raise or something, if you're done with the pretest, so we can see how much longer to wait.
The thumbs up disappear after a moment. So maybe if people could turn on the cameras when they're ready to go. How's that?
I've also been tracking who had their thumbs up too from the things. I think we're like about a third or half of the way through, but thank you guys so much. Okay, I think we are good to move on. Feel free to just complete the pretest as I move to the next slide if you haven't finished it. So we are going to start with a clinical case. Vicky, do you mind reading this case for us?
Yeah, a 50-year-old man who is 177 centimeters tall, identifies as Black, recently quit smoking after 50-pack years. He initially presented to primary care clinic with a shortness of breath with exertion and returns to clinic to discuss the result of the spirometry obtained. You note that the spirometer automatically defaulted to GLI Black reference equation to calculate the Z-score.
And the Z-scores that they calculated using these reference equations for FEV1 was negative 1.259, for FVC, negative 1.283, and for FEV1 over FVC is negative 0.062. And then the first poll question that should come up is, what pattern does this spirometry show? Normal, obstructive, possible restrictive, or don't know. Oh gosh, okay. So let's say A is normal, B is obstructive, C is possible restrictive, and don't know would be not filling it out. Yes, Lindsay. Okay, interesting. That's so interesting. Even split. I was not expecting this. Can someone, I wonder how many people would have chosen don't know. Can someone who picked B or obstructive explain why they thought that this represents obstructive pathology? Maybe Hassan, do you mind telling us what you picked and why?
Yes. So I thought that so I don't really actually know how to interpret the z-scores that well in terms of like how they relate to the percentages, but I thought that the FEV1 and FVC were reduced by a negative z-score, but the FEV1 to FVC ratio wasn't relatively reduced as much given like the lower absolute value, but it was still negative. So for that reason, I thought of it as like preserved FEV1 to FVC ratio. And so I went with like the non-obstructive choice. So they're slightly
Sure, yeah. No, that's exactly right, right? Like, so when we think about obstructive physiology, when we interpret spirometry as obstructive, we'll see an FEV1 over FVC ratio that's abnormal. When we look at restrictive pathology, you're looking at the vital capacity, and that would be considered abnormal. And what you may not know yet, but we will discuss during this presentation, is what the lower limit of normal is with z-scores for abnormal physiology. And the cutoff is actually negative 1.645, which is 2 standard deviations away from the mean, but we'll go through that. So technically, while lower than the normal, this spirometry by z-scores using the GLI Black reference equations would be considered normal. Does anyone have any questions about that?
Can I ask you a question? I usually like rely on this percentage of predicted thing for like the actual lung volumes. Like for the FEV1 to FVC, I'm like, okay, it's less than 70 or it's not. But then like for the other ones, I kind of like rely on the percent predicted and I didn't have that information here. So I was like, I don't really know. And is that calculated from the z-score?
Oh yeah, so the z-scores and the percent predicted are both calculated from a comparison to like the normal or the means, and we'll talk about where they get those numbers more later, but I think we're supposed to be using z-scores to rather than the percent predicted. But I think that was a change that happened somewhere between medical school and residency for many of us. So I was taught with percent predicteds too. Okay, I'm going to continue moving forward. I have an activity for you all. Yeah, so Dr. Adamson says percent predicted is out, z-scores are in. I have a breakout room activity for you all. In the chat, I'd like you to use this GLI calculator, which is the calculator that uses the reference equations that we use to calculate to do spirometry interpretation. But this time, instead of using the GLI Black or African American reference equation, use the race neutral equation with these same values to calculate their z-scores. And then what I'd like you to discuss in your breakout rooms is how this would change your interpretation, your diagnosis, and your next steps for management for this patient.
And I think they're going to need to put in his height and age. So reminder, he's what age, what height? 60 something, 177 centimeters?
Yeah.
50
and 100, sorry.
Okay, I'm gonna re-put that in the broadcast because I don't think people can see the links once they go in the breakout rooms. And then let me add, or do you want me to add the height and weight? Is it the height and weight we needed?
They should be able to see it too from the chat because you can see the chat in the breakout
Can
rooms.
you? I feel like sometimes I can and sometimes I can't.
So they definitely need the numbers though, because they don't see the slides, right?
Yeah, 177 centimeters, 50
and
or
then
so.
you have to go from the post bronchodilator. FEV1 2.7, FVC 3.4, FEV1 over FVC 0.794.
Don't need the ratio. It calculates that. They just need FE1.
Oh yeah.
Oh wait, sorry. What else do they need?
FEV1 is 2.7, FVC is 3.4. Rosemary, the poll everywhere just didn't work. We would have had to register everyone.
Too many people.
Yeah,
It's like some weird thing with the UW, like poll everywhere is like participants have to be pre-registered.
What's a pain?
You can't like register yourself. It'll just say like you have not been pre-registered for this poll. Yep. And there's apparently the option to disable that is like grayed out. Like you can't disable that right on your end.
What pain?
Yeah.
Well. Ananya, as you discuss this, will you be explaining where z-scores are derived from?
Yeah.
Okay.
Yeah. I think. Oh.
And when you come back to that, Ananya, a z-score of 1.645 is the same as a standard deviation of minus 1.645. It's not two standard deviation. Yeah.
The z-score of 1. Okay.
Yeah, that would be a z-score of 2, -2.
Yeah.
And -2 to +2 would have 95% of the confidence interval inside it, but they didn't
just
do that. They adjusted it because they wanted to put 5% below. For the FVC, you kind of don't care about the upper limit. Like that's not a pathologic entity, that's just big lungs. So we're only interested in the lower limit for the vast majority of these numbers. And so we put the whole 5% at the lower end and came up with this ridiculous number to remember, which is -1.645.
Yeah.
So it's a one-sided, it's essentially making a one-sided version of, so if this is normally distributed, the ±2 standard deviations is that normal. I see what's happened here.
Let me show you. Sorry, let me go through all these slides. Here we are. How
long?
long do you have in break rooms?
Yeah, well, I can bring them back whenever. So they've been in
Do you
there
want to
for.
give them a 1 minute? Do you want to give them a 1 minute warning?
Yeah.
So this is my like Z-score slide.
Yeah, it's taking a while. It's lagging, I think, because you clicked through so many slides to get to it. But I know what the slide looks like, and this is the right slide. It's going to explain it.
The other analogy, if it's helpful for you to use, we commonly see this with osteoporosis, right? Like with DEXA skin. And so if people are familiar with thinking about T-scores versus Z-scores in that, it's somewhat of a similar analogy.
Yeah.
It's the same math. And the percent predicted is, it's has nothing to do with a normal distribution. Like, it's just very simple math based on what is 100% predicted, based on what is average from the normal distribution. And it never made sense. It only worked for a very small population, like men around 50. And it didn't work for anyone else. And I don't know why we did it for decades and decades.
I didn't realize we weren't doing it anymore, so I'm glad that I attended this talk. I did not get that memo.
It was like 2017 where they said Z-scores forever.
Because I mean, like the old PFTs that I'm teaching the med students, they don't have Z-scores. They just have so I guess we need to get new ones.
You have to put the values into that GLI calculator.
Yeah.
But then you have to talk about other things.
Yeah. So most PFTs are currently printed with both percent predicted and Z-score. It's like a slow change happening, which is a little confusing sometimes. But anyway, maybe people should come back from.
Yep, I'm going to bring them back now.
I had to come back to the main session because we don't have the numbers in the breakout rooms.
Oh, I thought I broadcast them. Did you guys not see them? Did they not come up on the messages, or do they disappear?
It's also possible I just can't work computers or something. Anyway.
I think some of the numbers came up, but not the post, maybe.
Okay. Was anyone able to do the breakout room activity?
No, I don't.
No, but we're all just.
Oh, we were able to do it.
Who is that?
This is Christine, and then Hannah, Austin, Danica, and Caleb.
Oh, great.
We did it.
Do you want to tell us? Do you mind sharing what the activity was? And I'm so sorry, you guys, that the link that we that you didn't have the slides. Thanks, Jared. Christine, do you mind sharing like what you found when you?
Yeah, I don't remember. I think we might have actually just put in the post. We either did just the post or just the pre, but we did it with the race neutral and then with the African American equations. And I think with the race neutral, the Z-scores for the FEV1 and FVC were more like negative 1.7 something. And then if you do the African American equation, it's like negative 1.2. And we were talking about how maybe like the Z-score cutoff is like 1.6 something, which is like 2 standard deviations, so that it might actually underestimate if you use the African American equation. And that's how far we got.
Yeah, that's exactly what I wanted you guys to get out of that. I should correct myself. The Z-score of negative 1.645 is 1.645 standard deviations away from the mean. And we'll talk more about normal distributions and standard deviations later in this talk. But I misspoke earlier. But that's exactly right. So the Z-score, when you're using the race neutral equations for these same values, is much less than the Z-score for the Black reference equation, which puts you in abnormal lung function when using one reference equation and within normal lung function when using the other reference equation. I'm going to pivot now to talking about the racial history of spirometry to explain more about why race has been integrated into pulmonary function testing and the background there. So We will start in the 1700s. Before the spirometer actually existed, people were discussing differences between lung function between Black individuals and white individuals. Chief amongst these is Thomas Jefferson. I know you guys can't see the timeline yet, but he wrote this treatise called Notes on the State of Virginia. And in this treatise, he's describing different physical attributes that differ between enslaved Black people and white people. And he specifically cites lung structural differences. He says that Black people consume less oxygen as one of the differences that would justify continued enslavement of Black people. It wasn't until the 1840s that the spirometer was actually developed in the UK by John Hutchinson, and this was the first time that lung function could be objectively measured. Following this, Samuel Cartwright, who is a Virginian physician and slave owner, built his own spirometer and used it to quantify the difference in lung volumes between enslaved Black people and free white people. He referenced Jefferson's argument that Black people consume less oxygen to explain the 20% difference he calculated between Black enslaved people and similarly sized white people. At the end of the Civil War, Benjamin Gould wrote a book describing the bodily characteristics of Black and white soldiers. And again, he reports a difference in mean lung volume between Black and white soldiers that persists when adjusting for height. This data was used during Reconstruction and into the 1920s to argue for white supremacy, notably by Frederick Hoffman, who is an insurance adjuster, who wrote his own treatise explaining increased mortality in Black individuals after emancipation. And then this sort of research finding that there's a difference between Black and white individuals' lung function continues into the 1970s. Based on all these studies and this data from these individuals, our medical establishment has incorporated race-specific reference equations into pulmonary function testing. And we've been interpreting pulmonary function using race-specific equations for decades to make our management decisions for patients. I am going to pivot to discussing race-specific equations in more detail and the race-specific equations that we currently use to calculate our Z-scores. So, and again, I'm so sorry for the laggy slides. I can see what you see, and I know there's purple timeline over this, but hopefully you can see a little bit of this slide. So the Global Lung Function Initiative developed the reference equations that we are currently using. They took a large group of non-smokers without respiratory disease, and then they sorted these groups into 4 different populations: Caucasian, Northeast Asian, Southeast Asian, and African American. You'll notice the exclusion of a lot of the world's population. So South America is excluded, Indian subcontinent is excluded, and the African continent is excluded due to lack of data. These curves here demonstrate population-specific regression analyses for FVC by age, with the mean fitted FVC shown. And you can see that this data found that based on among the racial populations that the GLI defined, they find differences between the mean FVCs of Caucasians, Northeast Asians, Southeast Asians, and African Americans. And these are this data is what built the race-specific reference equations and normal distributions that generate our disease scores. In 2017, the American Thoracic Society recommended using these equations based on self-reported ancestry, but before that, we were using other race-specific equations or correction factors to interpret pulmonary function tests. Okay, so now we'll talk about Z-scores and interpreting PFTs based on a normal distribution. So when an individual gets pulmonary function testing, their results are compared on a bell curve matched to their age, sex, and height. This generates a Z-score that indicates how far away a person is from the mean. Z-score of 1.645 is a standard deviation of 1.645 away from the mean. They chose this cutoff because under 5% of the reference population is expected to have a value lower than the Z-score. Okay. And again, the GLI race-specific reference equations create these race-based normal distributions for the different populations that they designated. I know the slides are laggy, but you should be able to see two separate curves. The purple curve represents the normal distribution for the white reference equation, and the turquoise curve represents the normal distribution for the black reference equation. These yellow arrows that will appear soon represent the point at which the Z-score would be less than negative 1.645 for each of these normal distributions. And you can see that the black normal distribution is left shifted as compared to the white. If you take this line, this purple line here, which let's say that's our patient in the first case, you can see that while his Z-score, his FVC, and then the Z-score for the black reference equation would be within normal limits for the normal distribution here, it's outside of the lower limit of normal and would classify as abnormal lung function using a white reference equation. I'll pause here just in case anyone has questions about that.
I have a question. I'm wondering, like, so with the data that was, and you may not know the answer to this, but like the data that was used to create some of these normal distributions, were the different like race/ethnicities that were used, were those based off of like the different data extracted from those populations, or were there weights applied to like the pooled data? And you may be
yeah, so that's a great question. They applied weight. So these are all population specific normal distributions. So when they created the race neutral equation, and we'll talk about this a little bit, they applied statistical weights because the population that they have is like 80% white. And so like it's most like the Caucasian curve is the most like robust, and then they were able to like bring in enough of the other ethnicities to make individual normal distributions. Okay. Okay, so let's go back to the GLI population and the differences in lung function that were seen between the different racial groups defined by the GLI. Samuel Cartwright and his peers concluded that the discrepancy in lung function between races indicated a biologic or genetic difference between races. But in the 21st century, we know that race is not an appropriate proxy for genetics. So my question for you guys, and I would appreciate if you guys could use the chat to answer this, is what other factors might be responsible for the differences in lung function? Hassan says environmental exposures. I wonder if you could be more specific. Yeah, I think about smoke. I was in LA before this, so I always think about freeways and who has to live next to the freeway and who lives in the hills. Where we put toxic waste dumps, where we put sewage plants. I think environmental exposures are huge. Is there anything other than environmental exposures that might impact someone's lung function or that might impact someone's physiology? Yeah, so height is incorporated into the normal distributions. All the normal distributions are for a certain height. Weight doesn't, I don't think weight impacts lung function, and it's not something that we see incorporated into the into our different normal distributions. I'm not familiar with the Cormick index.
I think it's just the proportion of like sitting height to standing height.
Correct. You're right, Hassan.
Okay, yeah.
It doesn't account for everything. If you put it into statistical analysis, then it will explain some amount of the differences, but it doesn't completely explain the differences. So there's more. There's more.
Oh, interesting.
Someone also messaged me in utero exposures, and I'll just show you my slide. Some of the research done in what factors impact lung function. Environment's huge, right? So occupational exposures, air quality. The other things I'd mention are early life exposures, prenatal exposures, exposures to maternal stress, nutrition, and poverty as independent risk factors for worse lung function. And these are all exposures that would vary between racial groups. And we know that on average, Black people in the US are exposed to more or higher levels of these damaging exposures. So the argument grows as we focus on this, that including race in reference equations just normalizes differences in population lung function, and that these differences can actually be better explained by disparities in socioeconomic determinants of health. Therefore, people have been pushing in recent years to move towards the use of race-neutral equations, which would unmask the health consequences of social inequalities for certain populations. So that sounds great, right? Like the idea of a race-neutral equation is like this panacea for all ills. I think when you think more about what race-neutral equations are and how they're developed, it becomes a little more complicated. So I mentioned before that in March 2023, the American Thoracic Society recommended the use of race-neutral equations. This schematic demonstrates what the normal distribution curves would look like for the white, race-neutral, and Black reference equations developed by the GLI. So that's what was in that calculator that I had you guys use earlier. These reference equations, the race-neutral reference equation, is developed using the exact same GLI 2012 dataset and arbitrary racial categories as the race-specific equation. So the like Northeast Asian, Southeast Asian, limited data set that's 80% Caucasian. They did apply statistical weights to account for the predominantly Caucasian sample. Hassan and whoever else is interested, there's a really interesting op-ed by a pulmonologist at UCSF who's arguing that these statistical weights were chosen without any clear justification, and that there's like a statistical argument that is a little bit over my head about how the race-neutral equation was actually developed in a way that is maybe less evidence-based. And so it's an imperfect tool. Pause here for questions about the race-neutral equation. Okay. So imperfect tool and different from the race-specific equations. And so I think when we think about what do we do now? Like, how do we use these two imperfect tools, especially in the wake of the ATS recommendation? I think it's the most important thing is to really focus on what the clinical implications of using race-neutral equations might be. Okay, so slides are lagging, but I see that you're starting to be able to see these two plots. This is a study done by a researcher at the University of Pennsylvania who took two populations of individuals, Black individuals and white individuals, and directly compared the use of race-specific equations to race-neutral equations in each population. So in these graphs, the change in the number of individuals with each PFT interpretation is represented by the horizontal lines, moving from the race-specific equations to the race-neutral equations. Green lines indicate resolution of the interpretation or the impairment, and the red lines indicate new respiratory impairment. The thickness of the line corresponds with the number of individuals whose interpretations changed. For white individuals, the race-neutral equations mostly led to resolution of non-specific pulmonary impairments, with some results being reclassified as obstructive. For Black individuals, the biggest change was in the number of normal individuals reclassified as having a restrictive impairment, almost 10% of the cohort studied when using a race-neutral equation. And this is what Christine and her group found when they used the GLI calculator for the sample patient. Okay. The same study showed that the application of race-neutral reference equations led to reclassification of the severity of disease for both Black and white patients. For Black patients, there was an increase in the severity of disease. And for white patients, there was a decrease in the severity of disease. And I like this study a lot because it illustrates what will actually happen to our interpretations of pulmonary function for both Black and white individuals as we move towards the race-neutral PFT equations. Okay. So now we have to think about what the implications are, right? So we can see that using race-neutral reference equations will lead to an increased number of abnormal pulmonary function tests in non-white patients, which means that non-white patients are more likely to be diagnosed earlier. But there's other clinical implications that I think are really important to touch on. And one of them actually, Dr. Lynch's slides alluded to as well, when we think about like interventions and how we're using spirometry and lung function testing to provide care to people. So question for you guys, question in the chat if you feel up to participating. What are some effects that you could anticipate from a switch to race-neutral pulmonary function testing? Can you explain the transplant? Yeah, so this is big, right? So on one hand, you have like more interventions, more testing, more referrals, which is a good thing, and maybe you could argue is like overburdensome, but it's good, right? So it's an overall net kind of positive. The increase in medication costs, I think higher life insurance premiums would go into the negative category, and then disability qualifications would be something like more people are qualifying as disabled, and that means that more people might be ineligible for certain jobs. And then the big thing that people have been talking about recently and that you might have heard about is who gets offered surgery for lung cancer. And I'll talk about that study next. The one thing that I was thinking of during Dr. Lynch's slides is, we use FEV1 greater than 20% of predicted to determine who gets lung volume reduction surgery, which would be can offer huge functional improvements in people's lives. And so if all of a sudden, you know, you had this FEV1 cutoff that is like drops down below that 20%, then you're ineligible for this surgery. Okay, so let's talk about what happens with lung cancer surgery and race neutral, or the and the different reference equations. So in this study that came out in August 2023, they gave 225 thoracic surgeons this clinical vignette of a 71-year-old woman with a right upper lobe non-small cell lung cancer. They were randomized to one of 3 groups receiving a different percent predicted postoperative FEV1 value, which is the value used in clinical guidelines for lung cancer treatment recommendations. So the value of FEV1 in liters was the same, but the percent predicted varied depending on reference equations used. Surgeons either receive values calculated with the GLI African American reference equation, the other reference equation, which was where they put all the people who didn't fit into one of the racial categories, or the multiracial people, and the white reference equation. And a confusing thing about this study is they actually say that they're using the race neutral or non-corrected reference equation, but when you do the calculations, they are just using the white reference equation as the race neutral reference equation. So in this range, right, this range of FEV1 from 42 to 49%, there are no clear recommendations for surgical management. And so surgical approach varies based on like surgeons' decision-making, right? That's their like clinical decision-making gray zone. The primary outcome that they were assessing was treatment recommendations. Surgeons either recommended lobectomy, wedge resection, or radiation therapy. And lobectomy is the only curative treatment for lung cancer. So this study found that surgeons randomized to the race-neutral reference equations were less likely to recommend lobectomy than those using the African-American reference equations. This group, the African-American reference equation group, was more likely to recommend wedge resection or radiation, which can have worse clinical outcomes for patients. Pause here to see if there are any questions about this study. Okay. I'm actually going to skip this return to case, and I'm going to move into the summary slide. Oops. Okay. So in summary, today we reviewed the history of pulmonary function testing. We learned that race has been used in pulmonary function testing due to both racist beliefs regarding physiology of Black enslaved people and studies like Benjamin Gold's Survey of Soldiers, and most recently the GLI 2012. And just to point out that arguments that Black people had intrinsically worse lung function were used to support slavery and support racial power structures. We also discussed that exposures to pulmonary irritant stress and malnutrition might explain racial difference in lung function. These exposures differ due to structural inequalities between races, and rather than accepting that certain racial groups have intrinsically worse health outcomes, we should move towards addressing the social, economic, and environmental drivers of those outcomes. And then finally, and most, kind of like interestingly for all of us, we're making a move from race-specific reference equations to race-neutral reference equations. And this is going to have clinical implications for our patients of every race. Their access to care and eligibility for treatment may change. And we need to be very thoughtful about how these institutional changes or spirometer setting changes are going to impact our patients based on their race. I have a slide here with a list of recommended reading that I use to develop this talk. There's a lot more. And so if you have any particular questions, I'm happy to give you the primary literature that I read. I want to thank Rosemary Adamson for helping me so much in developing this talk and teaching me everything I know about Z-scores. Also would like to thank Nirav Bhakta, Laura Granados, and Neha Deshpande, who are readers of these slides and of my script as well. I have a post-test that hopefully won't take that long for you guys to fill out. I will stay on as well if people have questions.
Thank you, Ananya.
Yeah, thank you so much. That was great.
I'm wondering, in your own clinical scenario that you presented there, what you would do with the information in terms of the fact that you have sort of two different, one being abnormal and one being normal, how you would use that information in your own clinical care of that case.
Yeah, I mean, I think that that's kind of the question, right? Is like, how are you using it, and how will it change your decisions, right? So there's this interesting thing that happens at the VA where I've heard, and Rosemary can like back me up or tell me if I'm totally off base, but I've heard that some patients are like pretty savvy and will say like, okay, well, this, this spirometer, like this equation is going to qualify me for some benefit. So I'll go here, and then this will like let me get more care. So I'll go to this other place and I'll use like this different equation. So I've heard that some VA patients with lung disease are savvy enough to spirometer shop, because some spirometers are set to use the GLI, like race specific equations, and some are set to use the race neutral equations. It's kind of a mishmash. It's a little bit of a mess. And so I think the key takeaway is like, how am I going to use this interpretation? Am I going to use this to provide care? And is this care going to be like totally burdensome to my patient, or are they really suffering, and like, do they need this like intervention? Do I want to work this up anyway? Like, what is my personal pretest probability? And just remembering that like these equations are not necessarily like completely objective or like should be used as a be all end all. That is a long.
I'm gonna jump in and try to give a couple other thoughts as well. I mean, I'm totally wrestling with this and speaking to lots of people about it. Like so many things in medicine, we talk about not using one piece of data to make a decision. So I worry less about this for my patients or for patients seeing a pulmonologist. I worry a lot more about things like decisions by insurance companies or other institutions that are making, financial decisions about disabilities and things like that, because they may well be taking just one number and using no other information. For our own patients, I do hear absolutely what Ananya is saying, the idea that, if a patient is referred to pulmonary for dyspnea on exertion with normal PFTs, that is a vignette that I see. And those patients will still get a CAT scan. And I will still poke looking for what the cause of their dyspnea on exertion is. So there's the one scenario that has always been the case of, if somebody has a symptom that is truly problematic for them, then we don't stop with one test, we keep going. And so in terms of things like resection, lung cancer resection, I think that's a really interesting area where I'm really pushing to see if we can get the companies that develop the software software that we use for PFT interpretation to print much larger reports, perhaps using more than one equation. And that's going to be super confusing. And it's going to be hard work to explain that to your patient. And I think that's the kind of level of data that we need. So there's this question from Clinton about what would be better. And my short answer to that is we don't know yet. And there are smart people thinking about this. And there are a couple of suggestions, and there are some advocates for genetic ancestry. And to do that, that means you have to get a blood test. So you have to take your patient who was coming to get, the benign procedure of a PFT, and then say, now I'm also going to stick you. And we're going to do a genetic test. Like, I'm just imagining how that for some number of people is going to be a big no-no. They're going to say, no, you're not taking my genetics. Like,